Hey friends, welcome back to our channel today. We're going to talk about a very important medical emergency: convulsions, or fits that don't stop. This is called status epilepticus, where convulsions last more than 30 minutes or come back to back without regaining consciousness. Imagine a patient falls in front of you and their body is shaking non-stop. This can be life-threatening if not handled in time. Like a doctor explaining, I'll tell you step by step how to manage this, from causes to treatments. The video is long so that all details are clear. So keep your notes ready and watch till the end. Let's start. First, let's understand what convulsions are and why they happen. These occur due to epilepsy, infection, or loss of consciousness. In status epilepticus, the patient doesn't recover between episodes, and this can lead to brain damage, respiratory failure, or death. Common causes: brain injury, low blood sugar, electrolyte imbalance, or complications in pregnancy. Remember, in pregnant ladies, avoid some medicines like phenobarbital or levetiracetam in the first trimester. Instead, valproate is safe. Now symptoms: the body becomes stiff, limbs jerk, foam from the mouth, breathing issues. If this lasts more than 30 minutes, ICU-level care is needed. Think like a doctor. First, keep the patient safe, then investigate. Immediate action is the most important, like a first responder in an emergency. First, protect the patient from injury. Prevent falls, insert a mouth gag to avoid tongue bite. Hold the limbs, but not forcefully, just support them. Keep the airway clear. Insert an oropharyngeal airway if breathing isn't maintained. If SpO2 is low, give oxygen via mask or nasal prongs. And if that doesn't work, start endotracheal intubation with ambu bag ventilation. This will safeguard the airway, because in convulsions, aspiration risk is high. Along with this, monitor oxygen level with pulse oximeter. Check blood sugar stat because low sugar can trigger it. Now investigations. Send blood samples for CBC, blood sugar, serum creatinine, blood urea, LFT, serum electrolytes. These will tell if there's any imbalance, like low sodium or calcium. Do brain imaging CT scan or MRI to check for any tumor, bleed, or infection. Don't miss these steps because knowing the root cause makes treatment targeted. The main part of treatment: injections and medicines. Let's go step by step, like climbing a ladder. First step: benzodiazepines for quick control. Inji diazepam, calm pose, 10 milliliters, 0.5 milligrams per milliliter. Slow IV stat along with thiamine, 100 milligrams IV stat to prevent Wernicke's. If not controlled in 5 minutes, repeat. Alternative: injalorazepam, 2 milliliters, 1 milligram per milliliter, IV over 2 minutes, 0.1 milligrams per kilogram, and if needed, repeat after 5 minutes, or Inji. Midazolam, 5 milligrams IV slow. Then start drip 0.2 mg/kg/hr. These calm the brain like a sedative to stop convulsions. If this doesn't work, second step: Inji, phenytoin, dilantin, 100 milligrams in 2 milliliters amp, 5 to 20 milligrams per kilogram. Slow IV over 20 minutes, max 30 milligrams per kilogram body weight in 100 milliliters, NS/5% D-diluted. Make 10 amps per liter. Watch for hypertension and apnea. If BP drops, start dopamine drip if systolic below 90 mmHg. Third step: if still not controlled, Inji, phenobarbital. Slow IV over 20 minutes, 20 milligrams per kilogram, 5 amps 200 milligrams in 1 milliliter, 20 milligrams per milliliter. Then valproate 30 milligrams per kilogram in 100 milliliters, NS over 15 minutes, then 3 mg/kg/hr drip. Fourth step: in refractory cases, take expert guidance for further treatment. Inji, levetiracetam, Keppra, 20 milligrams per kilogram. Slow IV over NS, max 4,500 milligrams. Do not mix with 5% dextrose, or continue valproate. If this also fails, anesthesia level: diazepam, drip 100, mg 500, ml IV at 20 microdrops, min, 25 milligrams per hour. Loading 10 milligrams slow IV, then 0.25 mg/kg/HR. Or midazolam, 0.5 milliliters in 500 milliliters, 5% dextrose at same rate. Taper slowly when controlled, then switch to oral. For super-refractory, endotracheal intubation with ventilator support. Propofol loading, 20 milligrams per kilogram. Slow IV over 3 minutes, infusion 2. 5 mg/kg/HR, 50 milliliters per hour by syringe pump. Or thiopentone, pentothal, 5%, 500 milliliters in 5% dextrose stat IV, then infusion 15. 20 mg/kg/HR over 1 hour, then 0.5 mg/kg/HR diluted with dextrose at 30 milligrams per kilogram body. But in 100 milliliters, NS/5%, D 60 drops min. Alternative, isoflurane inhalation, 0.8-2% via Boyle's machine. Don't forget supportive care. For hypothermia, paracetamol IV, cold sponging, and if pH 7.2, 2, IV sodium bicarbonate, 4 to 6 milligrams, 50 milliliters. Slow IV 6 hourly. Dexamethasone, 4 milligrams IV stat if brain edema, then taper. In prolonged convulsions, muscle relaxation with ventilator if needed, and after 12 hours, muscle relaxants like vecuronium. Long-term, once controlled, oral medicines like phenytoin, 300 to 500 milligrams BD, carbamazepine, 200 to 1,200 milligrams BD, oxcarbazepine, 600 to 2,400 milligrams BD, sodium valproate, 500 to 2,000 milligrams BD, topiramate, 50 to 400 milligrams BD, lamotrigine, 25 to 500 milligrams BD, levetiracetam, 1,000 to 3,000 milligrams BD, clobazam, 10 to 40 milligrams BD. In pregnant cases, be careful valproate safe, others avoid. Prevention. Avoid triggers like sleep deprivation, alcohol, and regular checkups. Follow all this and the patient will stabilize. Friends, hope this detailed explanation was helpful. This is general info. In real life, consult a doctor. Like, share, subscribe for more. Take care.